All right, welcome everyone. Thanks so much for joining us for today's webinar on cardiovascular care and brain health in Native communities. My name's Adam Livengood. I'm a research program manager at the Institute for Research and Education to Advance Community Health, also known as IREACH. I quickly want to go over the Zoom features for today. On the bottom of your screen, you should see a chat option, which you can use to send messages to all participants, or you can send a message directly to the hosts. So please note that there's also a raise your hand feature. However, we do ask that you instead please type any questions or comments into the Q&A box at the bottom right-hand corner, and we will answer those during the designated Q&A time at the end of the webinar. So for today's webinar, we're going to provide a brief overview of IREACH, as well as our supporting research centers, Native Controlling Hypertension and Risk Through Technology, or NCHART, and Native Center for Alcohol Research and Education, or NCARE. Then our panelists will share their presentations, followed by a 30-minute moderated Q&A discussion section. After the conclusion of the webinar, you'll be given a chance to provide feedback through an evaluation survey, and a recording of the webinar will also be available on both the NCHART and NCARE websites, which can be accessed through our main webpage at ireach.wsu.edu. We're also going to send out an email with the link once it's posted, so you'll have a chance to access that. And now I'd like to welcome Dr. Gary Ferguson, who is going to be providing us with a brief overview of our research institute.
Good morning or good afternoon. I'm Gary Ferguson. I'm a research associate professor and the director of outreach and engagement at IREACH. And I'm going to share a little bit more about IREACH and who we are. We're at Washington State University, and we challenge the status quo and advance community health through partnerships and collaboration. We conduct research with rural, Native, Latinx health networks and populations with substance use disorders. Next slide. Our IREACH faculty belong to various colleges at Washington State University, and we partner with external collaborators at universities across the country. Our institute houses 3 primary research programs, which I will go into more details in the next slide. IREACH's Native Health conducts community-based research and education to improve health and reduce health disparities among American Indian, Alaska Native, Native Hawaiian, and Pacific Islander populations. We do this by working with both community and academic partners in community settings. We focus on achieving health equity, community outreach, and engagement in training and education. We have over 60 partners across the country, including tribal colleges, Native organizations, tribes, universities, and satellite centers, and that list is growing. And we're really happy to work with new partners all the time, especially as they share our passion for health in our Native communities and those that experience health disparities. We have Native Health, which is formerly Partners to Native Health, which is community-centered, as I shared, research, training, education to improve the health and quality of life for American Indian, Alaska Native, Native Hawaiian, and Pacific Islander populations. Northwest Heron, which is the Northwest Health Education and Research Outcomes Network, which is our practice-based research network, which improves the quality of clinical care and reduces health disparities in communities across Washington and bordering states. And we also, due to the population, especially in the Pacific Northwest, of our Latinx and Latino populations and Hispanic populations, we have some really great work in the space of community partnerships and focused academic research. Now I'd like to welcome Dr. Amanda Boyd, who is our co-director at IREACH, who will share information on Native Chart and NCARE, which are center grants housed within IREACH's Native Health Core. Dr. Boyd.
Thank you, Dr. Ferguson. Hello, and thank you for joining us for this webinar. My name is Amanda Boyd, and I'm an associate professor at Washington State University. I'm Métis and Daneza from the Peace River country of Canada, and I also co-lead the Native Chart and NCARE dissemination course with Dr. Gary Ferguson. So I have the pleasure of introducing these 2 NIH-funded research centers that are co-hosting this presentation. So within Native Chart, our aim is to improve control of blood pressure and other risk factors for cardiovascular disease in American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders with diagnosed hypertension. The center is comprised of 3 community-based intervention projects and 4 supporting cores. Next slide. So the NCARE Center aims to optimize alcohol intervention research for public health in general and our Native community partners in particular. We accomplish this goal by collaboratively engaging with research project teams and pilot projects to conduct research that yields high quality data while simultaneously meeting the unique needs of our partners. Next slide. So we work with 7 satellite centers located in Alaska, Colorado, Minnesota, New Mexico, North Carolina, Oklahoma, and Washington. The work that we do with these centers ensures that research topics are important to American Indians and Alaska Natives throughout the US, and outreach and dissemination efforts are amplified throughout the country. Next slide. And now I'd like to pass it back to Dr. Gary Ferguson to introduce our guest speakers for this panel discussion.
Thank you, Amanda. So we have an amazing webinar for you today. I'm very excited to help introduce our presenters, who I look up to very much, and the work that they do is amazing. So first off, we have Dr. Astrid Suchy-Dicey, is an epidemiologist and biostatistician with a PhD from the University of Washington School of Public Health. Her current research addresses the epidemiology, etiology, and consequences of vascular brain injury and Alzheimer's disease in American Indian, Alaska Native, and Native Hawaiian populations. She has more than 10 years of experience working with large longitudinal cohort studies, including the Cardiovascular Health Study, the Seattle Kidney Study, and the Strong Heart Study, with a focus on cardiovascular, renal, and genetic epidemiology. She also has a background in cardiovascular and neurological pathology and molecular biology. Astrid is a faculty member and investigator at IREACH, where she also serves as a member of the Methods Core. So we're really happy to have Dr. Suchy-Dicey present, in addition to our other co-presenters. And the technology is not working for me right now. Okay, let's see here. Sorry. Next up, we have Dr. Kristoffer Rhoads. He's a clinical neuropsychologist specializing in the evaluation and treatment of dementia and neurodegenerative disorders. He currently serves as a primary neuropsychologist with UW Memory and Brain Wellness Center. The specialty of neuropsychology involves the initial evaluation and treatment of people living with memory loss and dementia with attention to emotional health. In his own twist on care, Dr. Rhoads works with patients and their families long after diagnosis, helping them to live well during big life change by developing new social, physical, and creative or healthy habits, such as mindfulness, meditation, and consideration, with consideration of the unique needs of each individual he sees. He's a co-leader of the Memory and Brain Wellness Center's clinic, Project Echo Dementia, which is the extension for Community Healthcare Outcomes program, hosted at the Memory Hub. And he first came to UW as a fellow in the neuropsychology and returned after a decade of other clinical and leadership positions in dementia care. He currently serves as the board of directors of the Washington chapter of the Alzheimer's Association and was appointed as the chair of the Health Medical Care Subcommittee for the Washington State Working Group to develop and implement the Washington State Plan for Alzheimer's Disease. In addition, he is the chair of the BRE Collaborative Alzheimer's Disease and Other Dementia Work Group. So Dr. Rhoads, thank you for being here today. And we also have Dr. Thomas Grabowski, Dr. Tom Grabowski. He is a director of the UW Alzheimer's Disease Research Center. He oversees a multidisciplinary effort to further a precision medicine approach to Alzheimer's disease. This work aims to better define key steps in the pathological process and thereby identify new therapeutic targets that will help people with different variants of this disease. He is the imaging and biomarker core leader, working with the co-leader, Dr. Christine McDonald. Dr. Grabowski is a leader in both clinical and research efforts around neurodegenerative disease and dementia at the University of Washington. In his role as the medical director of the UW Memory and Brain Wellness Center and a behavioral neurologist, he leads a provider team that diagnoses, treats, and supports patients living with memory loss or dementia. He has made patient and family well-being a top priority in the clinic by helping people adjust to cognitive challenges over time and leveraging intact personal strengths. He also conducts research at the director of the UW Integrated Brain Imaging Center, where his group uses functional and structural brain imaging methods to understand how brain systems supporting memory and language are affected by neurodegenerative diseases. So thank you, Dr. Grabowski, Dr. Rhoads, and Dr. Suchy-Dicey for being a part of our panel today. I will hand it over. So first off, I believe we've got Dr. Suchy-Dicey.
Thanks so much, Dr. Ferguson. I'm so happy to be here. I'm going to go ahead and try to share my screen. First of all, is the sound okay? Good. Okay, I will share my slides. Hopefully you can see that. Please yell out if you have any trouble with that. I'm really happy to be here with the other panelists and with the cores and centers and to be able to share this work with everyone today. This talk is titled Alzheimer's Disease and Dementia in American Indians. And it seems that my buttons are not working to advance my slides, so I will do the clicky method. A little bit of background. Alzheimer's disease and dementia are a continuum of conditions that take up to 20 or more years to present, from early preclinical conditions all the way into dementia. Alzheimer's disease is a brain pathology and it can be a cause of dementia, but they are not interchangeable concepts or terms. Dementia is, on the other hand, a cognitive syndrome. It can result from Alzheimer's disease, or it can result from other insults such as vascular injury or others. Alzheimer's disease, however, is the most common cause of dementia in the general population. Some risk factors for Alzheimer's disease. This is a model of risk factors throughout the life course proposed by Dr. Livingston in 2020, which I think we'll hear a little bit more about later on, but I wanted to present this as an introspective into different factors that can contribute to risk of Alzheimer's disease, and the idea that these are modifiable risk features that may be related to health factors or social factors that can change over the course of a person's life, from early life, such as education, midlife, things such as traumatic injury, hypertension, obesity, on into late life with things like smoking, social isolation, physical inactivity, diabetes. And then, of course, there are other factors that are unaccounted for, or non-modifiable factors such as genetics, which account for a different set of risk features. And so these modifiable features throughout the life course account for up to 40% of risk for Alzheimer's disease in the general population. But the question is, are there health and social disparities that may affect this model, whether this model holds for American Indians and Alaska Natives or other underrepresented groups is yet unclear. There are racial ethnic health disparities in dementia. Some studies of health records in Northern California, in Canada, have found that actually there are similar rates of dementia, although a little bit higher in American Indians and Alaskan Natives, as in non-Hispanic whites, but that African Americans do have higher rates of dementia than those groups. However, these data may be subject to some bias or errors due to use of clinical data that may overrepresent people that have access to health care or health insurance. They may also be subject to bias if clinical standards for measuring dementia and assigning diagnosis of dementia, if those are not consistent for all groups, then of course using records that have dementia as a diagnosis may be biased. And so those sources of bias and error may result in undercounts of data in American Indians and Alaska Natives, suggesting that actually studies of population-based data may be needed. And so some have said that despite decades of research and calls to action for ensuring that healthcare is equal for all, that data for on these conditions is equal for all, this aim is still far from reality for many Americans. And in fact, there are data suggesting that Native peoples and Indigenous US peoples are least worried about things like developing Alzheimer's disease and dementia, with less than 25% expressing concern, and that the underlying reason for that is that they don't think they will even live long enough to get those conditions. More recent studies have found that self-reported cognitive outcomes such as cognitive decline are indeed a little bit higher in those groups. American Indians and Alaska Natives are almost 2 times as likely as white people to report cognitive decline, and that these factors, these findings are 2 times, and especially, are especially true for women who are more nearly 2 times as likely, and for younger groups who are more than 2 times as likely. And in fact, the oldest groups don't even make it into studies like this. Social disparities, of course, can result in health disparities. So thinking back to that life course model of modifiable features, some of these resources and environmental factors can contribute to health disparities, not just mortality and morbidity, but also some of these interim risk features such as Alzheimer's disease and dementia. Things in the physical environment, in the community, socioeconomics, education, nutrition, and healthcare can all contribute. As a result, we decided to conduct a study in a population to examine Alzheimer's disease and related features, including risk features, in a population of American Indians across the US. Our research goals were to describe Alzheimer's disease, to define normal and impaired cognitive function, and to examine risk factor disparities. This study was couched within the larger Strong Heart study, which has been going for more than 30 years now. We recruited all of the surviving participants from the original Strong Heart study. About 800 were still surviving at the time that we conducted the first exam in 2010, and then 400 of those were still surviving when we conducted the second examination in 2017. So we now have 2 examinations of repeat visits from the same individuals. These represent 11 tribes and communities from the Southwest, Southern Plains, and Northern Plains of the US. The age range is about 65 to 95 years old. And we did magnetic resonance brain imaging, cognitive and functional testing, and detailed clinical and medical history. It's like we have a little forward. So we collected cognitive test scores, as I mentioned, and what we found in this population was that cognitive test scores were overall lower than were expected based on findings from other populations such as non-Hispanic whites. In fact, they were lower than what would be expected for American Indians and Hispanic Latino populations as well. Our mean scores on tests such as the Montreal Cognitive Assessment, shown here on the left, were lower than cognitive diagnostic cutoffs for cognitive impairment for all 3 of those other groups, suggesting that either the overall distribution, the overall population is generally more impaired than other populations, or more likely that this test may not be functioning in the same way in this population as it does in other populations, and that adjustment of cognitive and diagnostic scores and adjustment of understanding of that test may be needed. On the right there are some other tests, including the modified mini mental status examination, which is also commonly used, and then some other tests. However, using these tests, we did construct an algorithm to evaluate memory impairment in this population. This is an objective method that is not subject to physician review or any kind of subjective evaluation. However, it does have some limitations, such as an inability to look at overlap in categories, and it is, of course, not sensitive to specific categories, but just as a first pass of trying to understand ways of categorizing this population, we looked at different groups of memory impairment, different, including memory intact, different deficits in memory, such as retrieval deficits, storage and encoding deficits, and those are different types of memory impairment. And overall, we found that about 31% of our population was detected to have some amount of memory impairment, and 17% had a type of memory impairment that is characteristic of neurodegenerative impairment or neurodegeneration, which is similar to Alzheimer's disease. And so that might be compared with the 14% of the general population of a similar age, suggesting that this is probably more consistent with that these tests may not be functioning and that these diagnostic cutoffs may not be functioning in this population, but rather than this having a much higher degree of impairment. Here we have also a flow diagram of memory impairment categories between visit 1 and visit 2, showing highly dynamic status changes over the 7 years between visit 1 and visit 2, suggesting that over that time period, the majority of those with impairment are later lost to follow-up. More recently, we have completed adjudication by consensus through case panel review of expert panel. And this is more of a gold standard for cognitive impairment review and assignment for both mild cognitive impairment and dementia. And then this third column, which is INMCI column, impaired not MCI, which is a kind of catch-all third category of not normal, but not fitting into those other categories. And what we found here was between 46 and 54% of our population actually appeared to have cognitive impairment, which is to be distinguished from our prior findings using an algorithm method for memory impairment. And so this is a broader categorization, but also interesting because this, of course, is a consensus panel by review using expert reviews. What we did find was Alzheimer's disease and vascular pathology also appeared to be equally important causes of dementia, which was unexpected because Alzheimer's disease is overwhelmingly the largest cause of dementia in the general population. We also found that traumatic brain injury was an important cause of this other impairment category, suggesting that it is an important cause that should not be overlooked in research in this population. And we've also did some empirical cutoff evaluations for that 3MSE and MoCA tests to evaluate what might be appropriate test scores for diagnosis of cognitive impairment, and found them to be somewhat higher than the mean scores that were identified for the overall population. And these are closer to, but still lower than what are used as cutoffs for diagnosis in other populations. So looking at the population risk features, we have, this is an accumulation of many years of study. Looking at that Livingston model, we have found that years of education is overall low. It has a low validity with baseline function or baseline achievement. And so it's possible that better contextualization may be needed for understanding cognitive achievement. Achievement appears to be higher than the achieved years of education. Traumatic head injury, as I mentioned, seems important for cognitive impairment and dementia. It's also quite high at 31%. This is representing the proportion of people who are self-reporting ever having had a traumatic head injury with or without loss of consciousness ever in their life. And we can't evaluate proximity or recency of head injury or how severe the head injury was. And so future research may need to separate out those considerations, but this is quite a high proportion. Hypertension is also very high at 81%. Alcohol use is very low at 16% of people having used alcohol at all within the last year. Body mass index is quite high with the mean BMI of 31. Smoking is quite common with 66% being ever smokers. Depression or symptoms of depression are common with 20% having a score that is consistent with clinical depression, and diabetes again is common with 50% having diabetes. And so overall, these risk features are generally higher than in other populations, although some may be somewhat lower or different than in other populations, such as alcohol use. What is unknown and unevaluated compared with the Livingston model include things like hearing loss, social isolation, inactivity, and air pollution. And so those are also opportunities for future research. So in a different direction from looking at risk features, we're also looking at cognitive resilience, and this would be better than expected aging or people who have better than expected cognitive performance for their level of brain pathology or brain image findings. So here we have a figure looking at one measure of cognition, the Ways digit symbol coding test, which is a measure of processing speed. And then on the x-axis is brain volume, which is a general measure of brain atrophy. And so that's one way of looking at cognitive resilience, but there are other cognitive tests or other measures of brain pathology or brain findings that could be used to look at cognitive resilience. And here we have kind of colored into three categories. The gray group would be people that have better than expected cognitive findings for their level of pathology. The blue group are the kind of average group, and then the red circles are the people that have poorer cognition for their level of pathology. And so that just kind of categorizes people on the scale of cognitive resilience. And so looking at cognitive resilience as a measure of better than expected aging, we found that cognitive resilience was associated with a number of factors such as education. People with higher education have better resilience. We also found that it was associated with clinical features like diabetes. People with diabetes had poorer cognitive resilience. People with depression had poorer cognitive resilience. And people with this SF-36 quality of life score is a positive aging feature. And so people with higher cognitive resilience had better quality of life, better social connectedness, lower pain scores. And so those all suggest that cognitive resilience is an important measure with health and social features. But the question, of course, becomes which comes first? Is the cognitive resilience leading to better health outcomes, or is it the other way around? And so that's an area for future examination. And of course, like I said, there are other ways of measuring cognitive resilience. And so this is an active area of research. An interesting thing is that there are measures that cognitive resilience is not associated with, such as BMI, hypertension, alcohol, or smoking. So those are interesting null findings, also suggesting that there are things that do not associate with cognitive resilience. And so it's interesting to understand the patterns of association with with positive aging and with negative aging. And so that was a brief overview in some of the work that we've been doing in this study to look at cognition, dementia, Alzheimer's disease, and aging in American Indians, in a population of American Indians. There's, of course, a lot more research and a lot of ongoing research, and I'm very happy to talk about it with anyone. Feel free to email me at any time. Of course, I want to acknowledge the many, many collaborators and staff that have worked on this project, and of course our funders through the National Institutes of Health and the University of Washington ADRC and Washington State University. Thank you very much.
Thank you, Dr. Suchy-Dicey. great information, and I know there's going to be questions, and so we will have time for dialogue at the end of our talks. So next up, we have Dr. Tom Grabowski, and I'll hand it over to you, Tom. Thank you.
Great. Everyone can see my screen?
Yes, thank you.
Thank you so much for inviting me. And I thought that was a wonderful first talk. And what I'd like to do is shift gears a little bit and talk about the underlying biology of what's happening. My hats at the University of Washington include directing the Alzheimer's Center and the Integrated Brain Imaging Center. And I'll try to give you the perspective of a neurologist and someone interested in the biological mechanisms of the disease on some of the facts that we heard Astrid talking about. So how cerebrovascular disease and degenerative brain disease interact, or maybe subtitled, why you should care about small vessel vascular disease. And those are our objectives. So, as a brain imager, we frequently work with these beautiful images like this three-dimensional reconstruction of a normal brain. And we lose perspective on the idea that the brain is actually an organ. The brain has not just neurons, but supporting tissue, connective tissue, and, for our purposes today, blood vessels that are just essential to the health of the brain. And I think one of the emerging themes of research is trying to understand the interaction between vascular health and brain health. So that's what I want to talk about today. If I like to explain it to my patients like this, if the brain vessels are like a tree with a trunk and branches and eventually twigs at the top, the problem that we're dealing with clinically is really at the level of the twigs. If you have a large vessel that sort of looks like the shape of that tree, you have one set of branches that come off the vessel, directly off the trunk of the vessel, if you will, directly off the trunk of the tree that we call the deep penetrating arterioles. And then at the crown of the tree, you have these very small branches or twigs that penetrate into the cerebral cortex, so-called cortical arterioles. And if you paint the brain in there, you can see that the deep penetrators are really coming into these deep gray matter structures in the brain that are connected most with motor and sensory function. And these penetrating arterioles that come in at the level of the cortex are coming into the part of the brain that's concerned with information processing and cognition. And then situated in between is an area that I'm going to call the deep border zone. This is the tissue which is farthest from the vessels and which sees potentially the least pressure head and is at most at risk when blood flow is low. So there's a diagram from a textbook which does a much better artistic job, but I wanted to emphasize the sort of tree nature of the vessels for heuristic purposes. So let's talk about these small vessels. And what I want to emphasize is that the small blood vessels are not just pipes carrying blood, but they are dynamic structures. They have a physiology that's designed to maintain a steady state of conditions inside the brain tissue, so-called homeostasis. So for example, the arterioles have a property called autoregulation. And autoregulation here means that over a normal range of blood pressure, these vessels will adjust their diameter to keep the amount of blood flowing into the tissue distal to them constant. In other words, they're regulating blood flow so that the tissue sees enough blood, but not too much pressure and not too much blood, if you will. And then if you get outside the range of autoregulation, below the minimum blood pressure or above the high cutoff, then you lose the buffering that autoregulation mechanism provides, and you can have consequences of that. That's been known for a long time. The emerging science is around something called the neurovascular unit. So at a microscopic level, there are important and very complex interactions between the endothelial cells that line the small vessels, the pericytes that are sort of smooth muscle that surround the vessels and affect their caliber, and the glial cells, or the supporting cells in the brain, that have a lot to do with the blood-brain barrier and the regulation of metabolism and other basic processes in the brain. And the neurovascular unit really does, in a sense, control the microenvironment of the brain. And one of the things which has been attracting attention in recent years is the idea that there are channels that are around the vessels, but not the vessels themselves, that we call glymphatic channels, that carry interstitial fluid out of the brain and essentially can clear protein and other degradation products in the brain from the system. And that glymphatic flow is highly dependent on restorative stages of sleep, because the channels open during deep sleep, and account for some of the potentially some of the deleterious long-term effects of interrupted sleep, as we typically see in patients who have obstructive sleep apnea. So small vessels are critical to regulating the microenvironment of the brain. We have a way of stress testing these vessels using imaging, because it turns out that the amount of carbon dioxide in the blood, because exerts a potent stimulus on the neurovascular unit, and if you have high PCO2, so you can do this by simply asking someone to hold their breath, or you can do this with a fancy machine that blends the gases and keeps CO2 a little bit high. The blood vessels dilate, and we like that. We like that they can dilate and accommodate more flow into the tissue if they're called on to do that. So that's why we call it a stress test. And you can see in the figure here, everything in orange and yellow is tissue that increases its blood flow when given this potent stimulus. And then you see these blue stripes, and this is in this deep border zone that I talked about a little while ago. And when you open up all the pipes, what happens is the deep border zone suffers and flow goes down. That's a little bit like, you have all the garden hoses on and you go to turn on the faucet in the sink and you don't have any water pressure, right? And it's sort of like that. That's a kind of a steal phenomenon. And it turns out that this area where the steal happens is precisely in the deep border zone, where we're going to see all the white matter abnormalities on imaging that we'll talk about in a minute. So this area is chronically at risk. This diagram I showed you, this is from normal young people, no pathology. So what happens then when the small vessels become diseased? And in Alzheimer's disease and related dementias, there's two kinds of things that happen to the small vessels. Typical effects of hypertension and diabetes lead to a hypertensive arteriopathy, sort of a proliferation of connective tissue, something called arteriolosclerosis and lipohyalinosis, and that causes a reduction in caliber in the vessels, but it probably also affects the physiology of the vessels. And then the other thing is that amyloid protein, that the same amyloid protein that causes plaques in Alzheimer's disease, also builds up in the small vessel walls and replaces some of the normal structure in those walls. And so then you have a situation where there's stiffening and replacement of the structure of the pipes, but also almost certainly interruption of the physiologic function of the small vessel. And when these things happen, blood flow can reduce and become chronically reduced in this deep border zone. And then develop these this reaction in the tissue that's caused by loss of myelin and some gliosis and probably some loss of nerve cells, glial cells that we call white matter hyperintensities, or T2 weighted white matter hyperintensities. And that's the white spots that I'm showing you here. Now, I'm trying to move this. There we go. You can see on the left, that is, we see white matter hyperintensities of that degree pretty commonly. It's pretty routine. And on the right is a more moderately severe situation where you have a lot of white matter hyperintensities, and you have this conspicuous, we call ventricular capping. Trying to point it out with my cursor here, right on the edges of the ventricles, and emerging evidence is suggesting that the capping part is actually showing degeneration of white matter tract. It's more of a degenerative than a demyelinative lesion. And that's significant because the long-range association fibers that are supporting cognition are running right there along the edges of the ventricles. So that's a sign of degeneration in cognitive systems. So that's what happens sort of at the level of the biology. Those white matter hyperintensities. And then there's another thing that happens, and this is a really important mechanism that we have, unfortunately, not a very good clinical handle on, and that's called cortical microinfarction. And I'm showing that here with this is a very high resolution, unusually high resolution MRI scan that was done on actually a cadaver brain, on postmortem brain. And you can see just a little tiny white stripe there. Squint, get close to the screen. You can see it kind of blown up here. That's one little cylindrical microinfarct, that goes through the thickness of the cortex. And you can see it here on the microscope. And this cortical microinfarction turns out to be a really important and really common accompaniment of small vessel vascular injury, and is probably responsible for a lot of the cognitive impairment that happens. So why should we care? So for one thing, vascular pathology is ubiquitous in degenerative dementia. It is rare that we have a case of altogether pure Alzheimer degeneration. It's even rarer that we have a case of altogether pure vascular degeneration. What we typically see is a mixed Alzheimer and vascular pathology. I'm showing you a pie chart here that comes from the ACT study, which is a population-based study of dementia risk that happens at Kaiser Permanente of Washington in Seattle, and is representative of a mainstream Caucasian population. With that caveat, what we see is population attributable risk for dementia, 45% for Alzheimer's disease and 33% for vascular brain injury. And if you look at the data, and the way to read this chart, this graph, is every vertical line is one person with dementia who was autopsied in the ACT project. And and what you see on the y-axis is a summed neuropathology score trying to estimate the severity of the degenerative change that was there. Color-coded for blue when for the Alzheimer component, red for the vascular component, and green for the Lewy body component. And what you see is lots of columns where there's 2 or 3 colors, and only only a minority of cases had pure Alzheimer type pathology among the demented. And if you look in the same study at the decedents who didn't have dementia, who died without dementia, you see a similar sort of assessment where there's sort of subclinical degrees of all three pathologies, but especially of Alzheimer's disease and microvascular injury. So the point is that the small vessel vascular pathology is common and an important player, and it's probably especially common in Native populations. Took note of Astrid's presentation where fully 81% of the strong heart cohort were hypertensive, 50% had diabetes. The mean BMI was in the what we would consider in the obese range, and in cholesterol. I'm not sure she mentioned cholesterol, but clearly there were lots of vascular risk factors to be thinking about. And so then if you look at the relationship between, now we're talking about Alzheimer's disease, if you look at the relationship between how severe Alzheimer's pathology is and the clinical syndrome, we divide Alzheimer's disease, pathologically speaking, into 6 progressively severe stages of tangle formation. And typically stage 3 and stage 4 are associated with mild cognitive impairment, and stages 5 and 6 are associated with dementia. If you look at what actually happens, this relationship can be favorably affected by factors like education and an engaged lifestyle that are associated with this phenomenon that Astrid was talking about, that we're referring to as resilience. But you can also be dragged back by co-pathology, by vascular disease, for example, by sleep disruption, which is kind of affecting, we think, lymphatic flow. And so that it's possible to have mild cognitive impairment instead of this classic stage 3 or 4. You can get mild cognitive impairment at Brock stage 2, which means years earlier. Or you might, in the absence of these adverse health factors and in the presence of an engaged lifestyle, you might be able to weather stage 5 Alzheimer's disease and have only mild cognitive impairment, or maybe no impairment. We've seen patients like this at autopsy. So this is there's an important synergism between the Alzheimer's disease process and the small vessel vascular disease. And I would argue that you want to distinguish between these sort of cognitive factors, which improve resilience and might have some physiologic explanation, and these health-related factors, which are sort of the opposite of resilience, so it sort of lead to more vulnerability in the brain. And then I thought I would just point out that, that we're moving into an era where the therapeutic effect of intervening on some of these factors is being studied more carefully. And I think Chris will talk about that more in a minute. I just have one slide here, which describes the finger study, which was a Finnish study to prevent cognitive impairment and disability that was pretty celebrated result and has spawned a whole set of follow-on studies that are called the worldwide fingers studies. But in the finger study, 1,260 at-risk Finnish seniors were enrolled. So this CADE score, this is a cerebrovascular risk factor aging incidence and dementia study composite score that takes account of things like age, education, sex, blood pressure, BMI, and cholesterol level, and gives you a score. A score of more than 6 means that you're at risk. And they enrolled people that were not cognitively impaired, but were on the sort of the lower end of normal. So they tried to enrich the study population in people who were at risk, and then studied interventions on diet, exercise, vascular risk monitoring, and cognitive training. And each of these with a lot of intensive effort, for example, 9 or 10, cognitive training sessions, using a specialized computer program that had been developed for the purpose, or coaching people through an exercise program, those kinds of things. And what you saw over the 24 months of the study then was a divergence between the intervention group in red and the control group in, I think that's blue, showing significant differences in processing speed and general cognition over that study period. So this is a randomized intervention showing that intervention on multiple factors can ameliorate the course of cognitive impairment. And then finally, I just mentioned that, aside from the routine problems with hypertension, diabetes, and small vessels, there is also this Alzheimer's specific version of small vessel vasculopathy called cerebral amyloid angiopathy, where the amyloid protein accumulates in the small vessels. You can see here, these are amyloid plaques in the cortical ribbon in this micrograph. And if you focus in, you can see not just plaques, but also you can see small vessels that have their walls filled with amyloid protein. And we're still learning about the physiologic significance of this, but it is clearly the case that it's an important contributor to the vascular brain injury that occurs in ADRD. And we've also sort of now created a strong need to understand this better, because we're on the cusp of hearing about the FDA approving an amyloid antibody treatment that removes the amyloid from the brain, called lecanemab. And when it pulls the amyloid out of the brain, it also pulls the amyloid out of these small vessels and can cause what are called amyloid-related imaging abnormalities. The vessel walls are replaced by this amyloid protein. And as you pull it out, the vessel walls can leak. You can have an extravasation of fluid. You can see that white signal here in the brain after treatment. That we call that area E. Area is amyloid-related imaging abnormalities, and E for edema. You can also have microhemorrhaging. That's these little black spots that you see here, so-called area H. We're going to have to wrestle over the next couple of years with rolling out a new therapy that can have this sort of small vessel complication, and I think will underscore the need for further understanding of cerebral amyloid angiopathy in ADRD. So that's kind of a whirlwind tour through small vessel disease. I hope I convinced you that degenerative brain disease and small vessel disease are intertwined. But at the same time, there's basic biologic aspects of small vessel disease in aging and ADRD that remain unknown. Like what causes cortical microinfarction? How do we detect it in life? Is small vessel disease part and parcel with Alzheimer's disease? Just to name two. And I think these are very germane to studying ADRD in Native communities, given the high rates of cognitive impairment and vascular risk factors. So with that, I'm going to close. And I think questions are going to come after Chris's section. Thank you.
Thank you, Dr. Grabowski. Excellent presentation to build upon some of the things that Dr. Suchy-Dicey shared as well. And we're really excited to have Dr. Kristoffer Rhoads wrap us up with his presentation, and then we will have time for questions and comments. So Dr. Rhoads.
Thank you very much. And I do want to do a time check. How are we doing?
We are doing great for time. You have the full time to present. So
perfect. Perfect.
Yes.
I do have a subspecialty in making up time, so if I needed to, I could. But I will trust that we're okay. And I'm going to trust also that you can see that okay. All right. So absolute pleasure and an honor to co-present with two of my favorite colleagues and in partnership with one of my, if not my favorite partners here. So really, really appreciate this opportunity. And you've already heard some wonderful things that I'm hoping to weave together and touch on just a little bit, kind of a very kind of a high level view of just some of the context, to talk very briefly about kind of what's normal, what's not, and then spend more time on what do we do to minimize the likelihood that we develop pathological or abnormal aging, especially now that we know that there are modifiable risk factors that shape that. I do want to point out too that this is a huge issue, and I don't think I need to convince you that there are increasing needs. You probably have a personal connection to the disease, or if you are a provider, seeing it. But we have a huge number of people with dementia. The number's around 60 million right now, and likely going to double by 2050. And I'll draw your attention to the fact that many of these cases, the majority, almost 60%, soon to be almost 70%, are in low and middle income countries with a high number of indigenous populations with dementia, and a higher number that have no diagnosis. So only 10% of all people with dementia likely have a diagnosis in places like India. Here in the United States, we have upwards of 6.5 million Americans with Alzheimer's disease, another 6 million with MCI, 3 million of whom are, this is due to Alzheimer's disease, and a high number with vascular brain injury or vascular cognitive impairment as well. And to Astrid's point about using healthcare systems and records as indicators of prevalence, here in the United States and here in Washington, only about 45% of people with dementia, not even MCI, but with dementia have a diagnosis. And only about 47% of providers that we surveyed here in Washington have any kind of clear pathway for detection, diagnosis, documentation, and management, any kind of clinical pathways for dementia in their healthcare systems or sites of practice. So I think we've got a little bit of a tip of the iceberg issue, and we have a population that is rapidly aging into this risk zone. So by the time you hit 85 plus, you've got about a 33-35% chance of having Alzheimer's disease or vascular brain injury. And as you heard a little bit about, we have huge disparities in who is affected by this. So 2/3 of all people living with dementia are women, and moreover, 2/3 of all caregivers for people with dementia are women. And we have disproportionate rates in some of our other populations compared to Caucasian counterparts. So about 2 to 1 for our Black and African American older adults, 1.5 times higher for our Hispanic, Latinx populations, who tend to be diagnosed at a later stage and more significant disease. And the data is still pending for our AIAN populations, but as you're hearing, it's likely close to 2 to 1. And I also want to highlight the importance of heterogeneity within these groups. And often there are more differences between, say, our Asian American populations or Pacific Rim populations than there are between, say, them and a Caucasian counterpart. And certainly highlighting the importance of all of these factors, not just genetics and biology, but the sociocultural and structural institutional problems that have limited access or participation in research. We know that we are an aging population, and this is very true for our American Indian, Alaska Native elders. So right now, there are about 10% that are over the age of 65. That number will come close to doubling by 2050. So that purple band in that last slide that showed the 85 group increasing, 85 plus group, that is true for our American Indian, Alaska Native populations as well. Knowing on top of that, they have disproportionate levels of things like diabetes, hypertension, hypercholesterolemia. As Astrid pointed out, about 35% maybe aren't so concerned about Alzheimer's or other dementias because they're thinking they're not going to live that long. But over half also perceive that not just mild cognitive impairment, but cognitive impairment to the point of dementia is just an inevitable consequence of aging. So there's a lot of work to be done around education and risk modification. So briefly, kind of visiting this idea of what's normal, what's not. So after decades and decades of collecting normative data around cognitive functioning, we have a pretty good model for what cognitive aging looks like. So around 65, there's a set of changes that occur in processing speed, complex attention, some aspects of short-term memory. Those continue as we age, but not to the point of causing any kind of functional independence. So that would be, or functional dependence. So that's characterized by this green line. However, whether it's vascular brain injury or accumulation of plaques and tangles that characterize Alzheimer's disease, for 6.7 million Americans, there is this other process that's occurring that yields very different trajectory in cognitive function and ultimately independent function. And I think the things that are important to think about here are There's a silent phase of that disease, the prodrome. There's the mild cognitive impairment phase, and then there's the frank dementia, which you can characterize a couple of different ways. Some stages there, about early or mid and late stage. But this is a long, slow-burning disease with multiple points of intervention, and ideally, the further upstream we are, the greater opportunity we have to make some impacts around preserving cognition and function, despite a disease that maybe can't be cured or fully prevented. You've heard a fair amount about why it is that we develop pathological or abnormal changes in aging. And when you survey the literature for both Alzheimer's disease, neurodegenerative disorders, vascular brain injury, there are some common related health conditions with synergistic interactions. I will point out that these are modifiable, some of them more easily modifiable than others, but these are not your genetics. They may interact with your genes to turn those kind of risk genes on and off, but many of the things that we've been talking about. And we know that those things are disproportionately prevalent in our American Indian, Alaska Native populations. And a lot of this work has come from the absolutely wonderful Strong Heart study, but there are other studies that would corroborate this with AIAM populations. So huge prevalence of hypertension and diabetes. In terms of hypercholesterolemia or dyslipidemia, that's 40%, higher than Caucasian populations. And there are also disproportionate environmental effects. So we've got some evidence that chronic low-level arsenic exposure is associated with decreased processing speed. We've got, for our tribal or coastal tribes, chronic low-level domoic acid exposure due to shellfish, razor clam intake. And then PCB exposure for older Mohawks yielding changes in cognition, but not showing up in our younger Mohawk tribal populations. We know, again, diabetes, hugely different in our American Indian, Alaska Native populations, and setting the stage for vascular brain injury as wonderfully outlined by Dr. Grabowski. Really nice study done at the VA, looking at American Indian veterans without any diagnosed cognitive impairment. Almost half had abnormal MoCA scores, and that gets to some of the data that you heard around needing to maybe modify either cut points or maybe even the whole instrument itself, whether it's a culturally appropriate or intelligent instrument. But with those a random sample of those individuals that had abnormal MoCA scores, only 4 had normal cognition. 5 had vascular MCI, 2 with full-blown vascular dementia, and then 4 with non-amnestic MCI, primarily due to traumatic brain injury. But again, very, very different numbers than if you pulled a random sample of Caucasian veterans. All right, so kind of you've got a good sense, I think, of the context and the stage. And when we think about treatment, independent of monoclonal antibodies or other disease-modifying, potentially disease-modifying agents, we have some other options as well. And my thinking about this is, we have this picture of gradually accumulating neuropathology that still doesn't have a vaccine or a cure at this point. But we do have some things that have some demonstrated efficacy around decreasing how rapidly that pathology accumulates. And the result of that is not, again, eradicating the disease, but keeping people functioning in a better state. So keeping them in a pre-symptomatic or MCI state. And the data would all suggest the further upstream we catch this, better efficacy we have in these efforts. And if you look across the literature around what are those things with any kind of demonstrated treatment effect, it's these things here. So number 1 is early identification and modification for cardiovascular risk factors. So addressing blood pressure, cholesterol, blood sugar, and insulin function, keeping people moving, making sure we are treating and optimizing sleep, treating disorders, minimizing alcohol use, making sure there's a careful survey of medications and supplements, over-the-counter supplements, cardiovascular exercise, keeping people's brains active and helping them form good strategies and systems. There's some emerging data around dietary interventions, so lots of attention around the Mediterranean and Mayan diet. managing stress well, and keeping people plugged into their communities. How all of these things translate into our American Indian Alaska Native populations, it remains to be seen. Certainly the thinking about decreasing rates of diabetes or hypertension, there's a mechanistic piece there, but some of these other things around diet, how people manage stress, these are all very culturally contained. Astrid did a wonderful job of talking about the Lancet Commission work. The only thing that I will revisit here is that, again, that idea that 40% of dementias are preventable and that this is a lifespan intervention. So maybe early life or midlife interventions around managing hearing loss or improving cortical or cognitive reserve, minimizing risks around traumatic brain injury. You might delay the onset of Alzheimer's disease. You might prevent vascular brain injury. But also this idea that even if you are diagnosed with something like mild cognitive impairment or early stage dementia, it's not too late, right? So that idea of intervening to ideally prevent progression, or at least rapid progression, from mild stage of disease to more moderate or severe stage of disease. And one of those other components, we don't have time to go through each of them, but maybe we can talk about some of them in the Q&A. Lots of attention around the role of exercise and physical activity. So I wanted to focus on this one just to give you a kind of an idea about it, and then maybe even more practically, how do you do it? Or if you're working with patients and families, how do you get them to do it? So this is the best studied and has the most robust data. And again, you can get older adults without cognitive impairment to exercise. You have greatly reduced the risk of developing MCI. If you have somebody with MCI, getting them to exercise, you have modestly reduced their risk of developing late-stage dementia. They may still progress, but slower with less severe symptoms. We now have meta-analyses about this topic. And there's a really lovely overview of exactly what might be the active ingredient here that was published in Hippocampus. That reference is there for you. So whether it's dendritic arborization or upregulation of brain-derived neurotrophic factor or vasculogenesis that comes from cardiovascular exercise. So there's likely multiple mechanisms of impact here, including improving sleep, improving mood, helping regulate some of those other conditions that are risk factors for dementia. And most of the really well done meta-analyses would say that there is an additional treatment effect if done in combination with other interventions. So not just exercising, but exercising and changing diet, or exercising and changing diet and doing something to keep the brain engaged. There's also really consistent evidence that would say exercising as a group has a greater treatment effect than doing it individually. So not that you shouldn't do it if you don't have a group, but there's an additional benefit there. There was a concern about, boy, do you need to go to an exercise class or a YMCA? But even home-based exercise yields the same kind of treatment effects, which was critical during the pandemic when people couldn't go to their normal exercise venues. How do you implement it? So for those of you who are providers and have ever tried to prescribe exercise, you know what happens. People have great intentions, and they come back 3 to 6 months later and they haven't done anything. So if you look at the literature around what dictates adherence to an exercise regimen, there's a couple things, including the fact that it needs to be scheduled and structured. I also think about this for my own kind of exercise, that if it's not scheduled, and I'll get to it sometime today, not gonna happen. Too many other things come up. So scheduled, structured, some kind of accountability. So that's why it's great to have classes or somebody who's going to come knock on the door when it's rainy and dark out morning in the winter. Physical therapists are wonderful for this, personal trainers, if that's financially viable. I'm also a big fan of exercise diaries. So here's an example of what I use in our clinic, which are pretty easy to fill out. You can do some shared decision-making around, well, here's the evidence, right? So it's either 20 to 30 minutes 5 times a week in your cardiovascular training zone, or maybe 45 minutes 4 times a week. What can you do? Where can you get started? What's your goal? The other thing is making sure people have a variety of activities that they're engaging. I think about kind of recovery and rehabilitation after an injury, that you start slow or start small and kind of go slow in terms of increasing. I'm also a huge fan of motivational interviewing and enhancement. Questions like, now that we've talked about the data, you know why I want you to exercise, but why do you want it? Why would you want to do this? Or, okay, so we've talked about how helpful it would be to start walking 2 to 3 times a week, for 20 minutes. On a scale of 1 to 10, how likely are you to do that? I'm a 5. What would it take to get you to 6 or 7? So those kinds of things. And then touching on Tom's comment about the finger study, which was the first landmark kind of multimodal intervention. And I will comment too that 80% of the participants adhered to that study, despite a long time frame and a lot of kind of components. So these things are pretty well tolerated, at least in Finland. We'll see about here in the United States, and we'll see in terms of other populations. But 2 very, very large cohort studies out of the Chicago area that looked at people doing, one or more of these 5 things, some of which we've been talking about. So changing your diet, moderate to vigorous physical activity along the lines of what we just talked about. That should be not smoking, and then keeping your brain active. If you do 4 to 5 of these things, you've got a 60% lower risk of developing Alzheimer's dementia or vascular dementia. You might still have the disease, but not progress to that late stage. If you do 2 or 3, that's about a 40% lower risk. And it depends a little bit on which 2 or 3 those are. But so again, just evidence that the things that we do, thinking about epigenetic phenomena, the things that we do may and clearly do have an impact on how we function later on in life. And with that, I think I am going to stop there. So we've got plenty of time for questions.
Yes, thanks so much, Chris, and to our other panelists for sharing those really informative presentations with the group. We're going to invite everyone to please ask any questions, or you can, as Gary said, post a comment or a topic for further discussion in the Q&A box. If you haven't done so already, we will go ahead and read those questions in the order that they're posted. And if we don't get to your question during the webinar, that's fine. There's still an opportunity for you to send your questions to any of the panelists following the webinar. Okay, so we have a question in the Q&A box. Annika Noreen says, just so I don't forget, I was going to ask Chris about the exercise. It's heart rate based. What about step based or otherwise? Is there any evidence for what metric should be used for exercise?
Yeah, that's a good question, and a kind of an emerging metric, but the best studies so far have looked at target heart rate. So that kind of being in your target cardiovascular training zone, so it's closer to 70 to 80% of your maximum for your age. And for a period of at least 10 minutes, for a while it was, you got to do it for 20 to 30, but pretty consistently, study after study, it would say you could do it kind of with like an exercise recess approach, but it's got to be at least 10 minutes. Other things like step counts, strengthening, stretching are great for fall prevention and maintaining mobility. But they haven't had the same kind of treatment effect in terms of cognition in late life for people with vascular brain injury and Alzheimer's disease. The only other thing that I'll add is there's an interest about, well, what happens when you add components of anaerobic or aerobic exercise, and is there a treatment benefit there? And there may be, but that's not entirely demonstrated yet either. So yeah, heart rate has kind of been the most consistently emphasized metric, which gets tricky when you got people who are on beta blockers and other things. You can also use perceived level of exertion as a proxy for that.
Excellent. Thanks, Chris.
So I've got one. I don't see any more right now. And of course, we got time. We have until 12:30 Pacific time with our webinar. But a question to all 3 presenters: what excites you about your work in this space? And from a modifiable risk factor, what gives you hope in working with our aging population, given the demographics? We've got a large silver tsunami coming. What excites you in this space, and what gives you the most passion in the work that you're doing?
I have a comment. So, I've been in this field for 30 years now, and in 1990s, we would see people in clinic who already had fairly advanced dementia by the time they came in for evaluation. And in the last 10 years, I'd say many more people presenting at a much milder phase of impairment, and maybe more to the point, a lot more consciousness and interest in personal brain health. I mean, I think it's an easy sell to people, really, that brain health is important, and and we have a lot of people that are asking questions every day about what can I do to reduce my own risk. It's a question that resonates with with all the groups that we treat in the clinic, and then we're seeing studies like Finger that are showing benefit, and so I think it's an exciting time for that reason. And we're developing new pharmacologic treatment, but I would say these effects are likely to be more additive, and we really ought to look into introducing this kind of intervention arm, this kind of non-pharmacologic intervention arm systematically into some of these trials. So I think we're at the beginning of the therapeutic age for this condition.
Thanks, Tom.
Yeah, I'd like to add on to what Tom is saying and what Chris talked about with interventions and preventative mechanisms. I think that that's really exciting. I think that it's great to see progress being made there, and that there's a lot of hope for being able to prevent these conditions or reduce the severity of these conditions. I'm also really excited. Tom mentioned this also, the increasing focus on resilience and strength-based elements of cognitive aging. I mentioned some of those data. We're just starting to look at those features. I think both in cognitive resilience, but also in psychological resilience, elements of aging that promote healthy, outcomes. And I think that it's really exciting to start looking at features that promote positive aging. The Livingston model has social isolation as a risk factor, but of course the complement to that is social connectedness. And I think after the pandemic years, we all probably connect to the idea of social connectedness being an important element for our own health and mental well-being. And, we've got some preliminary data, in the study showing that can reduce mortality. And I'm really excited to start looking at, whether that can also reduce brain, outcomes and cognitive aging. And I think that there's a lot of potential there for the future. So yeah, I guess I would say, to summarize, strength-based features and promoting strength-based aging is really exciting.
Thanks, Astrid.
Yeah, I guess I would echo a couple of those points. I mean, Tom's got 10 years on me, but in the 20 years, postgraduate school of doing this work, I am most excited about what feels like a much more individualized precision medicine approach to brain health and cognitive function, taking into consideration things like cultural and other contextual variables and the need for culturally appropriate measures, norms, interventions. I'm also super encouraged by the number of incredibly smart and motivated people getting into this field, which, the amount of funding for Alzheimer's and dementia-related research has gotten to the point where it probably needs to be. It still has a ways to go. And that, I think, coupled with just how fascinating this work is, has drawn a lot of super smart people and motivated people into this. So I'm continuously bolstered by that.
Thanks, Chris.
Thanks so much, Chris. Yes, I had a quick questions about that as well, just related to the cultural considerations in that piece. It's kind of a two-part question, but what are some ways that we can effectively increase ADRD awareness, education, and even screening activities in communities, getting folks involved? And what are some of the more important cultural considerations when researchers are looking to tailor prevention and intervention efforts, and even conceptualize this constellation of cognitive disorders within aging AIN populations?
Yeah, I'm happy to take an initial stab at that, but I think one of the things that I'm also encouraged by, and I think we still have a ways to go on this, is the cultural humility that's necessary for researchers and providers, right? I think a mistake we have made has been to design research projects and clinical programs and then go to communities and say, here's what we got for you. We know what you need. And that doesn't work, right? So that kind of bi-directional learning and partnering with communities around, what do you need and how can we help with that? And then who owns that? Who kind of is moving that forward. So I think there's an emphasis on that, which is really important. And I think also the partnering with communities to understand what the cultural determinants and definitions of abnormality are, right? I think back to this wonderful event that we did with the Yakima Elders Luncheon, where I got to do 50 cognitive screenings with elders, and several of them kind of chuckled and said, yeah, my short-term memory is not great. So what? That's not what's important. So I think we've got some work to do there too.
I think one thing that is important, one piece of the messaging in community talks I've given that's proven to be important, is to really help people kind of reframe, sort of temporarily reframe Alzheimer's disease and related problems. This isn't, it isn't dementia in 10 years. This is a 25-year process, with the 15 years being asymptomatic, right? And the way the math works out, if you could just slow it down by 5 out of those 15 years, you would cut dementia in half. And that idea, like, there's a reason to intervene before you have a problem. And I, what's coming is, we're going to be able to detect, risk with a blood test pretty soon. And the medicine for this is going to shift, in the 10-year time frame, it's going to shift into primary care. And we're going to be making these interventions earlier and earlier. So it's another, I think, thing to get across to people is the action is in brain health and prevention. I
guess the only other thing I want to add, and I want to make sure Astrid got a point with this too, but I think working on some of that misperception that, well, why get diagnosed, why get screened, because there's nothing to do, right? That kind of nihilism or stigma around dementia can be a barrier, or cognitive impairment can be a barrier. So I think getting that piece out around brain health, and there's so much we can do to optimize brain health, even if there's neurological injury, vascular injury, neuropathology.
Thanks so much. That's really interesting about the blood tests and what's on the horizon here for detecting cognitive impairment within communities. We have another question in the Q&A box. Have any studies on sleep quality shown that dementia can be delayed? In particular, sleeping at the same time daily, does that have a positive effect?
I think what's been demonstrated is that sleep fragmentation and obstructive sleep apnea in particular are associated with acceleration of decline or more decline. So it's kind of the flip side of the question. I'm not aware of any studies that have looked at the timing of sleep like that. I'm curious as to the reason the question was asked, but it's more the quantity of restorative stage sleep, deep sleep.
Great, thanks, Tom. Any other panelists want to weigh on that?
I would, it's a bit of a stretch, but I think about kind of our basic sleep hygiene interventions. And that's one of them. It's that consistent bedtime, consistent awakening time, no screens for 45 minutes before you go to bed. You know, these things that we can do to help optimize. So in that vein, you know, that makes some sense.
Yeah.
I don't think we've got hard data that would say, yes, it, you know, decreases the rate of amyloid issues. So it's also, to me, sleep is one of those kind of early frontier areas. I think we're going to learn so much more about that in the not too distant future.
Great, thanks so much, Chris and Tom. We have another question in the Q&A box. Have there been any interventions for APOE4 homozygotes, sorry for the mispronunciation there, that are promising?
Well, that's an interesting one. So, probably most people in the call are aware of APOE gene as being the strongest genetic risk factor that we know about for Alzheimer's disease. So if you carry E4, you have a higher rate of higher risk of disease, and E4 homozygosity, that is getting E4 from each parent, so 2 copies of E4, is associated with a 16-fold risk. So it's a big risk factor, not as strong as age itself, but still a big risk factor. It's hard to study because it's on the number of E4 homozygotes is kind of low out there. The interventions that are sort of emerging for removing amyloid protein do look like they benefit the E4 carriers more, and there's no reason to exclude the E4 homozygotes from the treatment pool. So we're hopeful that that's going to, give a clue to how to proceed with this, but that is a strong risk, and it's a factor. This wasn't the question, but I want to just say one more editorial comment or sort of comment for perspective, which is, if you have a copy of E4, that generally works out to, Alzheimer's disease presenting somewhere in the range of 12 years earlier than it otherwise would have. That's the kind of the strength of the risk. These kinds of lifestyle interventions that we're talking about probably easily have that same magnitude effect. So they're counteracting E4 carriage with these positive effects is realistic, and that's, I think, E4 carriers should definitely be thinking along those lines. Stay tuned on E4 homozygosity. Yeah.
Great, thanks so much, Tom.
Yeah, I was gonna add on to that. I would say a similar thing, which is like, rather than necessarily trying to treat E4, obviously you can't treat your genetics, but remove amyloid from those individuals because, of course, they've had a lifetime to be exposed, maybe identifying them as individuals of high risk for accelerated prevention efforts. And so, making sure to really target them for lifestyle interventions, because, of course, that might complement that risk with removing the lifestyle or modifiable risks from that model that we were looking at earlier. But what's interesting is that E4 as a high-risk allele may not translate to all populations. We have some preliminary data from the Strong Heart study suggesting that it was the E4 carriage of the E4 allele was not associated with imaging, cognitive, or other markers of brain aging, including that memory categorization in this population. And we weren't sure why that was. That was really a surprising finding. That's called a null finding. We were surprised to have that totally null finding in this population, especially given its strong effect in the general population. And it's unclear whether that's because there's high risk in people that are not exposed to that E4 allele. And so it kind of just balances out to everyone just having high risk. Or if there's resilience factors in people that carry that risk allele. And so everyone just kind of balances out to having lower risk, or if there's maybe a mixture of things, if there's gene environment effects interacting, or some other thing that's happening that's causing this to be a null finding. But we're still trying to look into that and understand why this is different for this population compared to the general population. It certainly doesn't mean that the biology would be likely to be different, and it does not mean that we should sleep on those modifiable risk features, because as we saw, those are much worse in this population. So we should probably focus on those and try to focus on prevention efforts. Yeah.
Thanks so much, Astrid, Chris, Tom. Looks like we're at time. If you had any other questions for those who are on the call that we didn't get to, just feel free to email us and we can direct those questions to our panelists. Thanks again to Astrid, Tom, and Chris for sharing their research and perspectives on this very important topic. And thanks to all of you for attending today's webinar. Please remember to complete our evaluation survey, which will pop up once you exit Zoom. You can also access the survey by clicking on the link that's included in our post-webinar emails. This is very helpful information for our research staff as we plan for future events, other dissemination efforts, and webinars like this. NCARE and NCHART typically host about a couple webinars per year, so do keep your eye out for any notifications on our social media channels and any emails through the listserv. So we hope to see you again at our future webinars. Thanks so much and have a wonderful rest of your day.